Hello, my name is Mohammed Ibrahim, and today we present to you a 40-year-old female with a past medical history of severe asthma, complex migraines, multiple allergic reactions, hypothyroidism, and suspected idiopathic angioedema, who was transferred to us after a 7-day stay at an outside facility. She presented to that emergency department with an initial chief complaint of recurring tongue and left lip swelling that had been refractory to over-the-counter diphenhydramine at home. For the past 8 months, she has had these daily recurrent attacks of left lip swelling, tongue swelling, left facial swelling, left abdominal swelling, and occasional left facial drooping. She stated that on a good day, the attacks can last for 15 minutes and resolve for 45 minutes before recurring, and on a bad day, the attacks last for 20 minutes and resolve for 10 before recurring. She has been hospitalized over 5 times for these episodes, but fortunately has never had any respiratory distress and never been intubated. Rheumatologic, neurologic, and immunologic assessments were performed to rule out any possible structural abnormalities, including normal C4 and C1 esterase inhibitor levels for hereditary angioedema. In the emergency department, MRI and CT scans were performed to rule out stroke. Her only positive finding was a mildly elevated ANA that is known to have a high sensitivity and a low specificity and cannot be used to confirm any rheumatic disease. Following the transfer to our facility, she had an episode of tongue and left lip edema and was given a 0.3 mg injection of epinephrine and a 25 mg injection of diphenhydramine. Within 5 to 7 minutes, her symptoms completely subsided. Given the subjective nature of her disease process, the lack of any respiratory distress, and the abnormally quick recovery following treatment, a psychiatric consult was placed to assess for a functional condition. During the evaluation, the psychiatrist found that when the patient was distracted from her symptoms and participated in 10 seconds of deep breathing exercises, her symptoms went into remission. When probed for life changes, she explained how her symptoms coincided with her son leaving the home after enlisting in the military 1 year ago. She also described a childhood history of abuse and abandonment. Given her social history, subjective reporting of symptoms, and relief of symptoms with diverted attention, the psychiatrist made a diagnosis of functional neurological disorder with mixed symptom presentation. She was started on 0.25 mg of p-clonazepam BID for 10 days to assist with the anxiety associated with her new diagnosis, and referred to outpatient cognitive behavioral therapy to work on coping techniques. Functional neurological disorder accounts for 5 to 10% of all neurological consults, with an annualized incidence of approximately 12 per 100,000 individuals. Functional neurological disorder classically presents as abnormal control of movement, episodes of altered awareness resembling seizures, and abnormal sensations. Previously known as conversion disorder in the DSM-4, the DSM-5 expanded the definition by removing the requirement for an association between symptoms and direct psychological stressors. The DSM-5 also removed the exclusionary criteria for diagnosis, allowing for more consistent diagnosis amongst providers using positive clinical features. Given the relatively high prevalence, it is very important to identify functional neurological disorder early and start cognitive treatments as soon as possible, as a recent study showed that 40% of patients with functional neurological disorder report similar or worsened outcomes 7 years after onset, despite an annual healthcare utilization cost of roughly $900 million. While many treatment options have been proposed in the literature, such as physiotherapy, electromyographic biofeedback, cognitive behavioral therapy, transcranial magnetic stimulation, and hypnosis, there is no gold standard approach, and each management plan should be individualized to the patient. Physical-based therapies have the strongest evidence and are based on the theory that abnormal movements that occur unconsciously, coupled with hyper-focused awareness towards those movements, can be reversed by retraining the brain to divert the attention elsewhere. Not only is it critical for the success of the patient, but the financial and resource burden on healthcare is also something to take into account. Stephan et al. Used national data on emergency department and inpatient visits in the United States between 2008 and 2017 to show an annual cost of $1.2 billion for adults and $88 million for pediatrics in regard to the healthcare charges incurred due to functional neurological disorder. This current case displays how a failure to diagnose functional neurological disorder early resulted in multiple hospitalizations, high use of medical resources, patient distress, and healthcare team frustrations. We encourage clinicians not to discount functional neurological disorder in a patient that presents with an extensive history of incomprehensible physical or neurological symptoms that seem to fluctuate with focused attention, not only for the overall health of the patient, but for the efficient and effective use of healthcare resources. Thank you for listening.